improving patient outcomes. So we are privileged to enjoy this teaching or this webinar together. And with us is Clifford Obuya, who is going to be our speaker today. Clifford is a seasoned sales and application specialist with over 10 years of experience in life sciences and molecular diagnostics across Africa and the Southern African Development Community. That is the SADC region. And we are privileged to have Clifford today to be our speaker. Clifford currently works for Heargen, I think since 2023. And at Heargen, he drives the adoption of cutting-edge life sciences and molecular diagnostic solutions. So in short, we are privileged to have a trailblazer in the industry. And Clifford holds a diploma in medical lab sciences. He has a BSc in biotechnology and also a master's in epidemiology and biostatistics. So with that, Clifford, if you can hear me, you can say hi and maybe we can start. So anyone who will have a question, you are encouraged to go to our Q&A section where you will be able to write your questions and we shall be able to respond to them at the end of this presentation. Clifford, if you can hear me.
Thank you very much. Can you hear me?
Yes, please.
Yeah, I don't know just what happened. What has happened to my presentation? Just a minute. Can you see my screen, guys?
Yes, we can see the screen.
Okay. So thank you very much for the lovely introduction. As I'm Clifford Obuya, I work for Heargen, and today I'm going to take you through multiplex syndromic testing for better patient outcomes. Okay. So my agenda is as follows. We're going to define syndromic testing. Okay, look at antibiotic stewardship. Also look at a very important aspect of the lab, which is diagnostic stewardship. We also look at the syndromic testing panels that are out there in the market. And then if time allows, we're going to look at the Heargen solution for syndromic testing, and then we have a question and answers. Okay, so what is syndromic testing? Okay, so what's a syndrome? A syndrome is a set of symptoms and signs that correlate with each other, and often with a specific disease. For example, a respiratory syndrome may include symptoms are headache, chills, fever, cough. Just a minute, having a challenge with my. Cough, muscle aches, and the signs are, which are very, very overlapping, temperature, fever, tachycardia, that is heart beating, wheezing, leukocytosis, and elevated TSR. If you look at all these symptoms and signs, they are not very specific, okay? And what is syndromic testing? Syndromic testing is a rapid sample to answer assay that is using a multiplex real-time PCR. And by here, multiplex means that you're looking at several targets in one assay to analyze pathogens that may be present similarly in a patient. Okay, so patient presents with symptoms and signs that are often non-specific, like we've said, fever, headache, joint pains, and then the clinician clinicians usually have difficulty in managing such kind of patient based on the symptoms alone. And if you look at the traditional lab protocols for diagnosis, you'll find that for the patient you have to do several different tests at the same time, and these several different individual tests may take a long time, or even days to get the results. Hence, you have a longer patient stay in the hospital. But if you go through syndromic testing, you do one test, target several pathogens at the same time. Being a PCR-based assay, in 1 hour, you get your results. And the results are very, very actionable and therefore improve the patient management. So syndromic testing can help eliminate the guesswork and facilitate faster clinical decision making. And this is especially important in high-risk patient populations. Okay, let's look at the antibiotic resistance, which is a very big problem in the current health setup. So antibiotic resistance is a growing threat to human health, whereby the antibiotic resistance is the ability of bacteria to combat the action of one or more antibiotics. And you can see here, by the year 2050, antibiotic resistance alone will kill more people than HIV, tuberculosis, and influenza combined. This is a result. This is based on the European CDC bulletin. And you can see in Europe alone, up to more than 35,000 people die from antibiotic resistance every year. And there are over 70% of health impacts of antibiotic resistant infection is directly linked to healthcare associated infection, which are nosocomial infection. And this could be minimized through adequate infection prevention and control measures, as well as antibiotic stewardship in healthcare settings. Okay. If you look at the three important bacteria that are common in the society, Klebsiella pneumonia and Klebsiella and E. coli, you'll find a very interesting trend that I'm going to explain. And you can see now we are working with the last line of antibiotics that are present. And you see there's a lot of increase in death, and up to 39% of the burden is caused by infection with bacteria resistant to the last line, such as carbapenem and colistin. So, and these are the last treatment option available for treating, for example, what I'm going to talk about, the Klebsiella pneumonia and E. coli. And the trends, if you look at the epidemiological trend from 2007 to 2015, the burden of each of the 16 antibiotic-resistant bacteria under study has increased, particularly, I've said, E. coli and Klebsiella. You'll find that from 2007 to 2017, the number of deaths attributed to infection with the Klebsiella pneumonia resistant carbapenem has increased by 6 times, and colistin resistant E. coli deaths have increased by 4 times. And this is very, very alarming. This is all data McHugh up to 2015. So we don't know from 2016 up to now what is going on. Okay. So what is antibiotic stewardship? Antibiotic stewardship refers to the coordinated intervention designed to improve and measure the appropriate use of antibiotic agents by promoting selection of optimal antibiotic drug regimen, including dosing, duration of therapy, and route of administration. The primary goal of antibiotic stewardship is to optimize clinical outcome while minimizing unintended consequences of antibacterial use, including toxicity, selection of pathogen, and the emergence of resistance. Okay, so with antibiotic stewardship, you're looking at the right drug, and looking at the pathogen, and avoiding the unintended outcome. Okay, so let's look at diagnostic stewardship, which is very important and it affects you guys in the lab mostly. Diagnostic stewardship is the process of modifying, ordering, performing, and reporting of diagnostic tests to improve diagnostics and treatment so that the right tests are ordered at the right times to improve the patient outcome and resource utilization. Okay, and diagnostic stewardship intervention can be used at any stage of the test process in the workflow, be it pre-analytical, analytical, or post-analytical stage. And then also diagnostic stewardship and multidisciplinary development process that may include input, from the frontline clinicians, subspecialists, that's our doctors, the antibiotic stewardship program, infection control, and clinical laboratory. Depending on this, the specific intervention. You see that diagnostic stewardship is it's how holistic multidisciplinary approach. Okay, let's combine the two. Sorry for a lot of introduction. The interplay between antibiotic stewardship and diagnostic stewardship. And I'll give you with an example. A patient walks into the hospital. The clinician or the healthcare provider evaluates the patient. Okay. And then request for a lab test. And at the diagnostic stewardship, you request for the right test to the right patient at the right time. If it's syndromic testing, for example, which is our topic today, and you're doing the rapid diagnostic test with the syndromic testing, the sample is taken to the lab and in the microbiology lab, and the PCR is done. Again, the result is forwarded to the healthcare provider or the clinician. Based on the results and relying on the antibiotic stewardship, the clinician will do the right interpretation, issue the right antimicrobial at the right time. So based on the lab result, the patient gets the right diagnosis and the right treatment. And if you see very clearly between diagnostic stewardship and antibiotic stewardship, there's one unifying factor. The common denominator is the right time. You do the right tests at the right time. You give the right antibiotics at the right time, because time is only of essence here if you want to save a patient's life, especially patients with meningitis infection. And we will see it as we continue the presentation. So why switch multiplex syndromic testing? One, for the laboratory, there are several workflow benefits. For example, it reduces the number of laboratory tests on an average from 3 to 1. Because, for example, if I look at the syndromic testing panel for gastrointestinal diseases, you are testing up to 24 different pathogens, meaning that those will have been 24 different test lines that you're supposed to do, but they're amalgamated into one. Also, the workflow, also the syndromic testing workflow potentially reduces the number of sent out tests, because you see, I'm sure there are so many. If I still go back to the gastrointestinal panel, you'll find that it tests bacteria, it tests the viruses, and it tests the parasites. For example, I don't think there's any lab that usually does viral culture and isolation. So if you have such kind of sample, you have to outsource. But with the syndromic testing, which is PCR-based, you can just do the test in-house. And then it reduces the average time to results by 84%. A normal culture will take up to 3 to 5 days, but one PCR syndromic testing, you get your result after 1 hour. Of course, this leads to faster turnaround time and increased productivity, and increased high detection rate means it increases the diagnosis yield. Many pathogens are identified or diagnosed at the same time. Okay, the clinician and the patient, of course, we move from, once you've used syndromic testing, we move from empiric treatment to targeted treatment, hence reducing the use of antibiotics. Again, it reduces time, also reduces time to microbial therapy. I talked about for example, meningitis. The test should be done very fast, and the treatment should be initiated very fast. Any delay can lead to death. Meningitis is usually an emergency. Okay. Also, multiplex testing leads to more targeted therapy. Okay, because you can diagnose many pathogens at the same time, and you can initiate targeted therapy to each and every specific target if the treatment is available. Again, it also reduces downstream procedure such as endoscopy and abnormal imaging, because the sensitivity of the test is very high. You know, PCR sensitivity is very, very high. So doubting the results, which helps in quick diagnosis of a disease. And then most effectively manage the patient isolation. For example, positive results can indicate patient need to be isolated, and negative results allows patient to be removed from isolation, especially during the COVID time when there was the quarantine. And then this multiplex syndromic testing help in such kind of activities. Okay, so syndromic testing has revolutionized the diagnosis of infectious diseases. And if you look at the lab, for example, I've just said there's the increase in sensitivity, diagnostic rate goes up. It also decreases the time needed to generate clinical useful laboratory tests, enable performance of laboratory quality testing with low expertise in molecular biology. That's very important because it's the workflow has been very, very, very simplified. For the clinician, the patients under appropriate treatment gets appropriate treatment sooner. It avoids prolonged exposure to unnecessary antimicrobial drugs. That's why I've said we have moved from empiric therapy to target therapy. It avoids avoiding the selection of drug-resistant pathogens, correct? Because you don't just shoot anywhere. Because when you target therapy, you know what you're looking for and you know what drug to use. It also strengthens antimicrobial stewardship practices. Exactly. It strengthens antimicrobial stewardship practices because of the targeted therapy. To the patient, of course, the benefit is the better outcome, and the administration reduces the hospital costs. So let's look at the syndromic panels available in the market. The most commonly used syndromic molecular panels for patient care throughout the world are the respiratory panel. And sorry, I'm going to use examples that with reference to Kajen, what we offer. We have the gastrointestinal panel and the meningitis panel. So let's start with the syndromic approach to upper respiratory infection, which is the respiratory panel. Okay. So before I go to the respiratory panel, I just want to explain a bit of ILI, or influenza-like illness. And what is ILI? ILI is a clinical syndrome defined as an acute respiratory infection with fever greater than 38 degrees centigrade, temperatures, and onset of cough within the last 10 days. Although influenza is common cause of ILI, multiple other respiratory pathogens are also known to cause ILI. The range of pathogens is non-specific to any single pathogen. Okay? Clearly, when you have ILI, people tend to suspect it is influenza, yet there are other pathogens that can also cause it. And the most priority pathogen for ILI, the priority ILI pathogens are influenza A and B, SARS-CoV, and respiratory syncytial virus. We also have other, as we said, we also have other ILI pathogens and several other viral and bacterial respiratory pathogens can cause ILI. Multiplex syndromic testing is important, especially in vulnerable populations such as children and immunosuppressed patients. So rapid detection of pathogen is particularly important to avoid the negative impact of delayed appropriate antibiotics. So what are the examples of other ILI viruses? We have the parainfluenza virus, rhinovirus, enterovirus, and adenovirus. And the bacterial ILI pathogens include Mycoplasma pneumonia, Bordetella pertussis, and chlamydia pneumonia. And if you look, majority of these ILI pathogen, I'm sure there are very few labs that are able to culture and isolate them, and are unable to culture and isolate them in the lab. But with syndromic testing, you don't have to go through that process. You just have to do the PCR and get your results. Okay, so what are the symptoms of ILI? Based on a publication in the journal of +1, the distribution of symptoms experienced by patients diagnosed with ILI are as follows. 95% of them show fever, 92% show cough, 51% show sore throat, and about 40% show myalgia. And if you look at all these symptoms, they are overlapping. It's not specific. So you cannot assign it to a specific pathogen. Okay. Trying to minimize. Okay. Having challenge with technology here a bit, but can continue. Respiratory testing symptoms. Respiratory symptom testing has a laboratory benefit, and I've just mentioned. It's a continuation of what I said earlier. It provides results in hours, not days, with more comprehensive diagnostic capability beyond just SARS-CoV and influenza. Compared to traditional testing, multiplex syndromic testing reduces the turnaround time to results by up to 25%. Syndromic testing also increases detection of pathogen compared to conventional method, including less common ELE pathogens, which you have seen up. Then in a single center study during the COVID pandemic, multiple cases of mycoplasma pneumonia were detected, including 3 co-infections with SARS-CoV, of which, if you are doing a single PCR, you'll have just targeted SARS-CoV, but with multiplex syndromic testing, you are able to get comorbidity that the patient might be suffering from. Okay. Okay. What are the benefits of syndromic testing for patient management? It reduces the uncertainty by rapid differentiating pathogens, exactly, because you have a panel of pathogens that you're testing, improve hospital isolation measures, and reduce the need for follow-up diagnostic tests. So you'll find with syndromic testing, it reduces the odds of antibiotics prescription in patients with respiratory infection. And as I said, we moved from empiric therapy to targeted therapy because we already know the pathogen that we're looking for. Okay, syndromic testing also significantly reduces the additional diagnostic testing. Example, as well as the admission in the ward. For example, chest X-rays, other blood tests, and you're going to see ahead in another panel for syndromic testing. And then rapid delivery of the results allows for early cohorting of children present with upper respiratory and lower respiratory infection, exactly separating the groups. And then many studies show that syndromic testing is associated with significant reduction in length of stay for the patient with respiratory infection. And this is very important, the length of stay in hospital. You remember also in hospital, you also have nosocomial infection. When a patient is sick, the immunity goes down and they're predisposed to nosocomial infection. But with syndromic testing, the turnaround time is very fast. The pathogen is identified. The treatment is initiated early, and the length of stay in the hospital or in ICU or in the ward is reduced. Okay? Okay. So the benefit of syndromic testing at the institutional level, we find that in syndromic testing, syndromic testing work to reduce the overall healthcare cost while supporting the improved epidemiological surveillance, which is very important. In some studies in Europe, a major integrated delivery network of cost saving were demonstrated in ICU patients tested for respiratory pathogen, of which over 9,000 USD saving for positive respiratory results. Those who are positive end up saving a lot of money, and over 8,000 saving for negative people who are diagnosed as negative respiratory infection. So multiplex syndromic testing also facilitates a significant cost saving in antiviral treatment of patients who had been diagnosed with community-acquired pneumonia and found to be co-infected with other bacterial and viral pathogens. I said that very important. The syndromic testing helps in identification of comorbidity and comorbidities and co-infection. For example, mycoplasma usually goes very clear in respiratory infection. Mycoplasma usually goes with influenza virus infection. which in other tests you will not be able to identify. But with multiplex syndromic testing, you are able to identify the comorbidity. Okay, multiplex syndromic testing also increases the detection of respiratory pathogen, which could enable better surveillance and help identify potential outbreaks early. This is very important. For surveillance, surveillance basically usually done based on season and time on and temporal based on time. So it's with syndromic testing, you are able to monitor the pathogens that are identified based on for example, the months of the year, the seasons of the year, the weather, whether it's hot, whether it's cold, whether it's rainy. You're able to classify and categorize your pathogen based on the variables that you want to do for surveillance purposes. Okay. So the impact of syndromic testing in the respiratory the impact of respiratory syndromic testing in a patient. There's a study that was done in Europe. It was a single center pre and post test children pre and post test of children with respiratory infection and visiting a Danish pediatric emergency hospital. And if you can see here very clearly, we're using the conventional methods, okay, and the normal laboratory PCR, you'll find that there were a lot of hospital admissions, a lot of blood tests that were done, up 78%, hospital admission up 71%, blood test up 78% of the patient that came in, and PCR, the normal PCR, up 6% of the patient that came in. But with syndromic testing, all these three activities reduced. For example, admissions reduced to 63% by almost 9%. What is really significant is the blood tests, from 78% to 49%, by almost half. The blood test means that the doctor's test is based on the symptoms that he's seeing, test for disease A, then it's negative, then thinks these symptoms overlaps with disease B, then tests and finds it's negative, like that. And you see, they end up wasting more time, end up losing diagnostic stewardship because they're just doing tests haphazardly and using guesswork. But with syndromic testing, one sample, for example, for the GI, gastrointestinal test, you test 25 different targets. That's why you see the blood tests based on syndromic testing reduced from 78% to 49%, almost by half. Again, you can see some lab tests are not used in isolation to manage patients. For example, if you do like laboratory PCR for chest infection, if it is positive, it warrants you to do a chest X-ray for you to be sure. But with multiplex syndromic testing, this additional tests reduced from 60% to 28%, and this is very significant. And to just summarize, with syndromic testing in this study, the reversed antibiotics prescription to non-prescription went back to there was reverse in antibiotics prescription to non-prescription in 46% of the cases, and there was significant reduction, reduced and significantly reduced the odds of chest X-ray and follow-up blood tests in hospital administration. That is the power of syndromic testing. Okay. Okay. And then diagnostic yield, the number of pathogens that can identify by one test. You see in syndrome, you see there is more positive cases identified when individuals with acute respiratory infection were tested with multiplex syndromic testing, and respiratory pathogens were detected in 93% of the children and 75% of the adults. You can see here very clearly where they are using immunofluorescent assay for diagnosis. This is for you see for adults they're getting 23%, but with multiplex syndromic testing, the diagnosis increased from 23% to 74%. Okay, For children, increased from 49% to 93%. That is the positive detection rate compared to the conventional method, which was IFA. Okay, and then the number of pathogens, detected. You see, when you're using the normal conventional rate, method, in adults, they got 4 pathogen, in children they got 4 pathogen using IFA. But with multiplex inverted testing, you can see the number of pathogens increasing. For example, in adults they got 8, and in children they got 9. So syndromic testing is able to detect more targets in one run compared to the conventional test method, where you have to do each individual, just shoot in the air, doing each individual test, and you're not sure if you're going to get positive or negative. Okay. So we've talked about the respiratory syndromic testing, and I wouldn't forget my dear company, which is called Kajen. We have a solution called the Castat. And if you look at our solutions, we have 23 targets for respiratory infection. We just use 300 microliters of samples that's collected and put into transport media. We have an overall sensitivity of 97.1% and 98.8% of specificity. And if you look at this number of viruses that we can identify, and the number of bacteria that you can identify with one swab, getting all these targets is quite phenomenal. And if you look at the workflow, in just 1 hour, you get your sample, your 300 microliters of your transport media, load it into the cartridge, put it into the scan the patient ID, load the cartridge into the PCR machine, the Castat. In 1 hour, you get your results. Okay. So let's move to the role of syndromic testing in gastrointestinal infection. Again, what is a syndrome? A syndrome is a set of symptoms, signs that are related with each other and often associated with specific disease and disorder. And gastrointestinal syndromes include the symptoms are diarrhea, nausea, abnormal pain, blood diarrhea if it's there, fever, discomfort, fatigue, and dehydration. All these are very, very overlapping symptoms and signs. You cannot attribute it to a specific target or bug. So if you look at the epidemiology of gastrointestinal infection, you find that there are 2 billion people, there are 2 billion cases globally every year, out of which 1 million visits the account, of which 1 million visits the emergency department, the hospital. Majority of the cases are children below 5 years, and of which here rotavirus is a key cause of diarrhea in children. And over 5,000 children die daily due to gastrointestinal infection. Majority of these cases are happening in developing countries, but also industrialized countries get incidents which are low, but the morbidity and healthcare costs are still very high. Okay, so let's look at the infectious versus non-infectious diarrhea. Diarrhea is the spotting of loose watery stool, loose watery bowel movement that may occur frequently with a sense of urgency. And if you look at diarrhea, they are divided into 2. The non-infective diarrhea, which is caused by antibiotics. When you take antibiotics, they interfere with the normal bacterial flora in the stomach, and that's creating discomfort. Food intolerance, for example, lactose intolerance can cause diarrhea. Inflammatory bowel disease, those are autoimmune disorders, can also cause that. Irritable bowel disease, those are celiac, those are autoimmune disease. Also, chemotherapy can cause that. And enteral nutrition. Infective diarrhea is caused by either viral, bacteria, or parasites. Okay. So, what are the limitation of the conventional testing for GI infection? What are the limitations when you have a gastrointestinal infection and doing the conventional testing? Using the conventional methods, many different time consuming tests are required to cover all potential causative pathogens. And remember, you are dealing with syndromes, so you don't know which pathogen, which pathogen you're looking for. Is it Salmonella? Is it rotavirus? Okay. Is it a parasitic infection? Maybe, for example, Giardia or Giardia. You don't know. So conventional tests for GI infection include stool for occult blood, white cell count, bacterial culture, microscopy for ovine cysts, ELISAs, and also PCR. But the limitation of this traditional method include multiple tests are required, and many pathogens have no specific available test. Correct. As I said, there are very few labs, if at all they're there, that can do viral culture and isolate them. Viral culture and isolate them in a normal clinical diagnostic setting. They usually rely on ELISA or chemiluminescence to do the diagnosis. Okay, and again, this traditional method are time consuming, can take even 2 days, even 3 days, even up to 5 days. They're labor intensive and tedious. You can imagine the workflow for isolation of Salmonella from stool, from media preparation up to sensitivity. It's very tedious and long. They're technically complex and require staff with specific expertise. Low diagnostic yield. That is very, very important. Low diagnostic yield. You get very few pathogens. Sometimes you miss other pathogens that are causing disease. Low diagnostic yield followed by low sensitivity and specificity. Okay. So the benefits of GI syndromic testing is as follows. It optimizes and consolidates your GI testing with a single test that is faster, more sensitive, requires minimal hands-on time, and allow you to rule in or rule out more pathogens. That's what I've just talked about. Sensitivity and specificity, diagnostic yield is increased, and the efficiency of the workflow in the lab is also increased. So high sensitivity and high specificity, the syndromic testing has got higher specificity and higher sensitivity compared to the conventional method, which has stool culture, which has got very low sensitivity and specificity. You end up missing some of the pathogen, especially the viral pathogen cannot be isolated in the lab. And then syndromic testing also can increase both positivity rate and the number of co-infection detected compared to conventional method. And I talked about it before. Comorbidities. It's very easy to pick comorbidities with syndromic testing because you're testing a battery of organisms. Like, for example, with the GI, you are targeting 24 different bugs. Again, it is faster turnaround time, and can result in better outcome and efficient and better outcome and better clinical outcome and infection prevention. Remember when you're looking at diagnostic stewardship, the right test, the right patient at the right time. So time is very important here. And I say, like with the meningitis, any delay is catastrophic. Even here in GI, any delays can be catastrophic. So if you compare syndromic testing to culture, you can reduce the hands-on time for technician, because syndromic testing is just once you've loaded your sample, just load it with the PCR machine, and PCR machine does the magic. Your technician remains with more time to do other workflows in the lab. Okay. So the patient management benefit for GI syndromic testing, gastrointestinal syndromic testing. What are the patient benefits? It contributes to better hospital resource allocation with faster, more comprehensive results that can inform patient workup, reducing unnecessary follow-up tests. We talked about that, and support earlier patient discharge. Length of stay is also reduced. So here goes by the reduction of extra diagnostic testing by up to 2.4% and time patient discharge by 1 day in patients with GI syndromes in comparison to controls which are the when you use the conventional method. Also, the cost is reduced. When the length of stay is reduced in the hospital, the cost of patient management is also reduced. Don't need to go into that. Compared to conventional testing, stool testing, Patients who received GI panel testing were less likely to undergo endoscopy. Exactly, extra test. When you do syndromic testing, it reduces the chances for you to undergo other extra tests to confirm the type of diseases you have, the type of pathogen that you have, because syndromic testing is very, very targeted and gives you a battery of pathogens that you can identify with one run. Okay. So, what are the consequences of GI misdiagnosis? One, inappropriate therapy, where there is higher clinical relapse, prolonged career states when they are not treating the right infection. So the patient is turned from being sick also and becomes sick and a career, and shedding all that infection and spreading it into the community or into the hospital that is admitted. And then unnecessary intervention, because it's empiric therapy. You don't know what you're looking for. And for example, if you have a Shiga-like toxin producing E. coli, you might end up developing hemolytic uremic syndrome, which damages the kidney. And then worsen the illness and post-infection sequel. You develop complications. You also have super infection because you're already sick and you go to the hospital. They're not treating you they're not treating the right infection. The immunity goes down. You also can get other nosocomial infections coming in. And I said also you can also develop hemolytic uremic syndrome, which I've just said, and post-infectious bowel disease, bowel disease. And then this also is also called the Guillain-Barré syndrome, which is also an infection in the GI. Okay, unnecessary side effects like microbiome imbalance in the gut or microbiome dysbiosis, Clostridium difficile infections, and rashes. And then most importantly, antibiotic resistance and outbreaks. It also predisposes the hospital community or the hospital environment to increase nosocomial infection and secondary disease transmissions. Also affects the isolation decisions because they are not sure if to preclude or include person in an isolation setup because they don't know which organism they're targeting, and they don't have clear path to identify the organism that they're looking for because they're using the conventional means. But if you use syndromic testing, it's very clear, targeted disease pathogen and targeted therapy. So early diagnosis facilitate timely and appropriate therapeutic intervention that can alleviate symptoms and prevent secondary transmission of infectious diseases. So let's look at the gastrointestinal testing and antimicrobial stewardship. So with syndromic testing, clinicians make more informed and targeted decision, minimizing inappropriate use of antibiotic and reducing the risk of AMR, antimicrobial resistance. Timely initiation of appropriate therapy leading to faster recovery time, hence reducing hospital stay and durations, and of course, saving money. GI syndromic testing also promotes judicial use of antibiotics, hence playing a pivotal role in safeguarding public health. Judicial use of antibiotic means that we now move from empiric therapy, which is guesswork, to targeted therapy because you already know the pathogen that you have identified, and hence reducing the chances of getting the risk of AMR. So, as usual with Kajen, which is a company that I work for, we offer solution for gastrointestinal testing, and the GI and the gastrointestinal panel offers 24 targets, just 200 microliters of fuel mixed in Cariblair or normal saline. You just add the cartridge here, enter the details of the patient, load the cartridge into the machine, and in 1 hour you get the results. And these are the organisms that we can isolate: the bacteria, the viruses, I don't want to go into the specifics, and the parasites. All these are identified with a clinical sensitivity of 96.7% and a clinical specificity of 99.99%. So we are able to rule in and rule out the presence or absence of a pathogen with a lot of certainty. Okay? So let's look at the meningitis and encephalitis in syndromic testing. So what is meningitis and encephalitis? So meningitis is the inflammation of the protective membranes covering the brain and the spinal cord. That is the meninges. It is caused either by bacteria, viruses, fungi, parasites, and also some infectious causes such as cancer and injury and injury to the head. The symptoms are sudden fever, sudden headache, nausea, vomiting, double vision, drowsiness, and stiffness. The treatment is usually either give antibiotics, antivirals, and in some cases, no treatment is required. What is encephalitis? Encephalitis is the inflammation of the brain. It is caused by virus, autoimmune disease, and rarely bacteria and parasites. The symptoms are moderate to severe fever, seizures, behavioral changes, confusion, sensitivity to bright light, and sensitivity to bright light. The treatment is usually, basically, because it's caused mostly by virus, and antiviral, especially a cyclic. So let's look at the global epidemiology of meningitis and encephalitis. There are over 2.5 million cases of bacterial meningitis globally. Meningitis is the second biggest infectious cause of death in children under 5, and bacterial meningitis kills in hours. That's why I say when you look at diagnostic stewardship, time is of essence. Okay? So for every 1 in 6 individual may die as a result of meningitis. 1 in 5 survive and end up with lifelong complications. So time to diagnosis is very important. A delay in antibiotic treatment is a strong independent risk factor for mortality. And I repeat, a delay in antibiotic treatment is a strong independent risk factor to mortality, with increased mortality observed after a delay in just 2 hours. Any meningitis or encephalitis suspected case is an emergency. Okay? So the central nervous system infection remains a major public health challenge. Meningitis epidemics occur worldwide, with the highest incidence rates in Sub-Saharan Africa. And I hope there's some bacteriologists here who understand the meningitis belt that comes from Senegal all the way along the borders of Sahara Desert up to DR Congo. But it's usually called the meningitis belt by WHO. Okay, the WHO has set an ambitious plan to defeat meningitis. The EU plans a major focus on expanding the use of evidence-based diagnostic tools, especially syndromic testing, for quickly confirming meningitis and improving the patient care. So there's a goal, an ambitious goal of defeating meningitis by 2030. Here's the roadmap. It's towards a world-free meningitis. So a collective vision is towards a world-free meningitis, because meningitis has so many causes, it cannot be eliminated or eradicated. There will be no world-free moment for meningitis, but we are committed to get as close as possible. This plan therefore aims to defeat meningitis as a public health threat, reducing the number of cases substantially and keeping them down. So what does this mean? We cannot eradicate meningitis, but with proper diagnosis, we'll be able to keep the infection down and reduce the incidences. So how does this plan goes? How does this ambitious plan move? One, by eliminating meningitis epidemics, reducing cases of vaccine-preventable bacteria meningitis by 50% and death by 70%, and then also reduce disability. And this disability, remember, results from delayed treatment and diagnosis, and improve quality of life after meningitis due to any cause. So, what is the role of this? What is the role of syndromic testing in this ambitious goal by WHO? One, syndromic testing will help it prevent epidemics by prompt detection of meningitis pathogens for quick initiation of public health intervention and outbreaks. Two, disease diagnosis and treatment, expedite the identification of specific cause of meningitis, allowing administration of correct treatment without delay. PCR, syndromic testing is 1 hour, so time is of essence. And remember, any delays in time when handling a meningitis case is disastrous. Disease surveillance, this is now epidemiology, offer a detailed insight into the prevalence of variety of meningitis causing pathogens, and this will be based on temporal time, season, and weather. Okay, let's look at the workflow for meningitis diagnosis. Any suspected presentation of meningitis diagnosis of meningitis infection goes through first step by lumbar puncture to collect the sample, or sometimes you can do some other tests like blood chemistry, blood culture, also do some scans. But once you've gotten your CSF sample, it undergoes microbiology and CSF chemistry. And in CSF chemistry, you look at the appearance of the CSF, whether cloudy, clear. CSF count the pleocytosis, count the white blood cells. Do the chemistry to check the level of protein and glucose. Also, sometimes do gram stain to look for the bacteria, whether they are gram positive or gram negative, and then also do the culture. This is now the conventional method. And then sometimes you can also go the molecular way by extracting the DNA extraction or RNA extraction and doing a single PCR workflow. And then if from these two workflows, a positive result, whether bacterial, viral, or fungal, results in targeted therapy. But the negative results in empiric treatment and potential discharge, because they don't know what they're treating. And this is what usually happens in the hospitals. With targeted therapy, especially when you're using syndromic testing, you know which pathogen and which drug to give. But if you don't get, if you miss the diagnosis using the conventional method, you result in now shooting in the air. These symptoms look like Neisseria meningitis, or this look like a viral infection, and then start shooting in the air, and the patient is not helped, and potentially discharge a sick patient to go to the community, which might lead to death, or any delay in treatment might lead to abnormality. Okay. So, importance of diagnostic stewardship in meningitis cases management. There's a study that was done, and there were two cohorts of which are adults and children. Adults and children, and in adults, any suspicion of the samples were brought to the lab with suspicion of central nervous system infection, and they used a very important tool to categorize the patients, the WBC count. And this WBC count created two arms of the study: those with high WBC greater than 5 WBC per microliter, and those with low WBC less than 5 WBC per microliter. And you can see very clearly those with high WBC, when genomic testing was done, there was a higher chance of getting infection or getting an infectious disease and an infectious bug compared to those with low WBC count. When they did the syndromic testing, they missed. There was no positivity rate. And you can see here from this study, they had 705 CSFs in patient, of which 1/3 of the tests from the patient, for 1/3 tests from the patient were very, very low and non-suspicious of CNS. Positivity rate was 6.5, and false positive rate was at 32%. Okay? But when you implement syndromic testing, they had 171 CSF cases, and the positivity rate was at 2%. So what does this mean? You don't have to do syndromic testing in any CSF sample that you use, that you get. For example, in adults, when you get a CSF sample, the first thing that you do before you set the assay is to check microscopy for the level of WBC count. If the WBC count is higher than 5 cells per microliter, it warrants you to do what? Syndromic testing. If it is less, it does not warrant you to do syndromic testing. Powerful tool of diagnostic stewardship. The right tests for the right patients at the right time. Let's move to the children arm of the children and immunocompromised people. And here, just to summarize, it says that with children and immunocompromised people, WBC count is not a variable to be used to categorize patients who are going to have the test, syndromic testing or not. For children and immunocompromised patients, any sample that comes in, you must do syndromic testing, and hence the power of diagnostic stewardship. Okay. So again, with Kajen, our solution is called CASTAD meningitis syndromic testing panel. We have 16, not 15. We have added cytomegalovirus to the list here. So we have 16 targets. Again, with 200 microliters of CSF, just load the cartridge, enter the patient ID, load the cartridge, the PCR machine, and in 1 hour you get your results. And your results can be either bacteria, viral, or fungal, with a sensitivity of 95.2% and a sensitivity and a specificity of 99.9%. Very high sensitivity and specificity. This does not create a room to do other tests to confirm the presence of the bacteria, and helps of bacteria, virus, or fungi, and helps help the doctor or help the doctor to move from empiric therapy, which is guesswork, targeted therapy. Therefore, assist in driving and antimicrobial stewardship and reducing antimicrobial resistance risk. So in conclusion, what are the clinical values of syndromic testing? One, reduce time to diagnosis, reduces the time to microbial diagnosis, provides a time to action advantage that helps healthcare provider to deliver efficient and timely patient-centered care. To detect one or more pathogens, I talked about co-infection. So syndromic testing increases the detection of pathogen and co-infections related to culture and molecular reference method. Okay. Support antimicrobial stewardship, very important. Multiplex PCR syndromic testing improves antimicrobial and diagnostic stewardship, improving therapeutic decision and reducing time to appropriate therapy. And I like using the example of meningitis, of CSF. Any CSF sample is an emergency. The longer you stay, the higher the chances of death of the patient. Improve patient management. Syndromic testing can reduce the need for additional diagnostic tests. Impact on infection control decision. Reduce patient length of stay in the hospital, which is very important, and hospital costs. And finally, with our CASTAD syndromic testing panel, you are able to see the CT values, and the CT values helps you to provide an additional layer of information and increases confidence in results, especially when complex and unexpected results are received. And another important quality of the CT values when you're doing syndromic testing, it turns your tests from a qualitative to a semi-quantitative results, where you can subjectively say this sample is positive for example, E. coli. There's medium, there's low, medium, or high infection. Semi-quantitative. You can just use those those terms. Like for example, when you're doing malaria, you have to do the pluses. +1 means low, plus 2 pluses means moderate, and 3 pluses means very high infection. Okay, with that, I have come to the end of my presentation, and I have one video that I'd like to show you. I hope it's gonna play. Let me just stop sharing this and stop sharing. Just a minute. And I'm going to share with you our CASAT syndromic testing system from Kajen. It's based on two modules: analytical module, and the operational module. And it's a modular system. You can touch up to 4 different modules, or 4 different analyzers. This is how the cartridge looks like. Molecular tool, it does extraction and the PCR. The PCR happens here. Yeah. Now you load your sample. And your cartridge. The cartridge has extraction capability to the DNA or the RNA. Prepare your master mix for PCR and do the PCR by itself. I'll show you how it does the extraction. Then loading your sample, the master mix to the digital wells. Here it's loading the samples, the master mix. Then go to amplification. Fast cycling method, there's not going to. It's acquiring the data. It's acquiring the data. Then gives you the results as positive or negative. It also gives you the specific values. Thank you so much. Now I invite questions about syndromic testing.
Yeah, thank you, Clifford, for that wonderful presentation. Indeed, it was quite elaborate, and I think it has elicited a couple of questions and concerns. And we are going to just bring in your questions and concerns at this time. Otherwise, I want to acknowledge those who have enjoyed the presentation. And Patrick Wanjiko says very informative.
Thank you.
Then Dorcas Ngeno says very interesting topic. I'm following from Bomet Central. Thank you, Dorcas. And then Jacinta Kabubu is saying interesting. And Fred Ottawa is saying, nice learning new things here. Kudos to the speaker. So I'm sure there are many, many people who have enjoyed the presentation. And from wherever you are logged into, allow us to now take a few questions. And Clifford, if you can hear me, the first one is from Alfred Mangera. He's asking, can it be used to diagnose Mycobacterium tuberculosis?
Thank you very much for the question. At the moment, we don't have a solution for this syndromic testing. There's no platform that is used for diagnosis of tuberculosis. Tuberculosis mostly is usually done on a standalone platform and a singlex or a single target PCR. So it's not part of the multiplex diagnosis, multiplex PCR for other lung infectious target, lung infectious or upper respiratory tract infectious target, infectious diseases. Yeah.
Thank you. And then I'll pick two next questions from Martin Jogona. He's asking, what are some of the challenges to implement syndromic testing in most of our health institutions? And then the second one, nowadays we have some county practicing telemedicine. How is it possible to apply syndromic testing?
That's very good question. The challenges of implementing syndromic testing, one is the cost. The cost is a bit prohibitive, but we are now working with we are lucky to be working with the insurance companies, trying to convince them to introduce the reimbursement programs for syndromic testing, and I think we are heading somewhere, which is quite exciting. And also there are also public institutions and are now adapting the syndromic testing workflows at subsidized costs. And we are seeing institutions like Kenyatta University Teaching and Referral Hospital has taken the flagship of introducing syndromic testing into their workflow, which is very good. Which is quite exciting. So cost is a bit of a challenge here, but with the reimbursement program coming in with the insurance companies, we hope that more institutions are going to adapt the system. And if the institutions are registered by the respective insurance, they can initiate the reimbursement program. Two, for telemedicine, I want to give you a very interesting scenario. We have been seeing the rise in syndromic testing here in Nairobi, and one institution that has got the tests usually help other hospitals to do the syndromic testing. For example, Hospital A has got the platform in their lab, so Hospital B outsources the services of syndromic testing from Hospital A. And I can tell you for sure, when they get an ME, when a meningitis sample, they release an ambulance to take the sample from Hospital A to Hospital B, where the syndromic testing is done. And the ambulance, you can imagine an ambulance coming with a siren. So once the diagnosis is done, the results is transmitted most of the time. The result is transmitted via online or other platforms, and the lab that does the test communicate with the clinician who has requested the test, wherever it is. So I think for me, that's a simple way of talking about telemedicine and what I've seen that's happening. Once the lab, that the central lab, the reference lab has done the test, it communicates directly with the physician in Hospital B who has requested for the test and give them the feedback of the result that they're getting. I hope I've tried to mention to answer the telemedicine part of the question.
Yeah, that's fine, Clifford. So maybe I can pick the next few questions. This is from Francis Kiboi. He's asking, how available is this technology in Kenya? and how affordable is it? I'm hoping you've answered partially. And then secondly, are there rapid kits or POCT gadgets able to run this Syndromic technology? Over to you, Clifford.
Okay, for availability, we have it's something that it's a journey and it's growing. We have footprints. The footprints are increasing. We have institutions like I won't mention names. We have institutions in Kisumu which have the machine. We have institutions in Mombasa which have the machine. In Nairobi here, in Eldoret, we also have institutions that have the instrument that can do syndromic testing. And so the footprint the countrywide is increasing. And in time, we hope to get, or I can just go ahead and mention the hospitals. If you go to Aga Khan in Kisumu, you go to MTRH, you go to Mombasa Hospital, you go to Pandia, you go to KTRH, you go to Nairobi here, you go to Pathcare Labs, you go to Dr. Kalebi Labs, you go to Aga Khan University Hospital, you get the syndromic testing platforms. So, and the footprint is increasing. And you remember, as I said here, cost is a prohibiting factor, but this is a journey, it's never a destination, so you're moving slowly with time. And with time, if you convince more insurance institution for reimbursement, I'm sure you're going to cover a bigger geographic area and increase the footprint of the testing. So for this technology, there is no RDT that you can use. RDT kit that you can load into the machine. This system, we usually call them the closed system. We provide you with the instrument. We provide you with the cartridges or the kits that you run on the instrument. Because if you do it open, if you keep it open, it's usually susceptible to malfunctioning, and hence it'd be very difficult to troubleshoot, very difficult to identify the source of the problem. But when we give you everything, we know we have optimized. We have optimized our assay. We know how it works. We have done a lot of. We have gone through a lot of challenges, and we learned with a lot of time where the possible problems are and how to fix it. But if it is put open, we don't know from company X brings their kit and load it to our machine, it will bring us a lot of problems. So, in simple terms, there is no RDT that can be put into that instrument to do syndromic testing.
Very well, Clifford. I'll pick a few comments also. This is from Godfrey Ogula. He's saying, nice presentation, Cliff, kudos. And then Audrey Baraza is saying, what an informative session. Now, Peter Rwako is asking, does this machine test for immunological disorders? If yes, share examples. Thanks for the excellent presentation.
There is no immunological disorder that can be tested on this instrument. We are testing microorganisms only, the bacteria, the fungi, and the virus. No any immune-related tests that can be done or can be tested on the instrument.
Thank you. I'll read this from, I'll pick a next question from Wilfred Moria. Okay, Benson Lucenaka is saying, is there any disadvantage when you are using syndromic method for patient testing?
That's a very interesting question. Any disadvantage? I would say only cost. That's the only disadvantage I'm seeing. It's a bit cost. It's a bit pricey, but if you look at the ROI, return on investment of the cost, is much higher. But the return on investment is much higher. I just see only that. I don't see any disadvantage, because it is highly specific, high sensitivity, high specificity, and high sensitivity, high specificity brings a lot of also other advantages. I don't see any disadvantage, my brother, apart from the cost.
Thank you, Clifford. And then this is from Wilfred Moriasi. Thank you, Wilfred, for the question. Between the patient, okay. Between the patient are okay. Between when the patient arrives in the facility, testing and treatment, I believe it will take more than 2 hours. In the presentation, you said that it should take less than 2 hours. I saying that you elaborate.
That timing is relative. What I meant is when the sample is collected and brought into the lab, it just takes only 1 hour to do PCR. Around 1 hour, 1 hour 30 minutes to do the PCR and get the results. So the turnaround time is faster, but it's not. I will not say that it's tagged exactly 2 hours, but the turnaround time is faster. So it takes you 1.5 hours to get the result, 1.5 hours to 2 hours to get the results. So depending on when the sample, the processes, the downstream processes before you get the samples might vary, because maybe the patient is at the emergency room, sample has to be collected and taken to the lab, but turnaround time for results is less than 2 hours, which helps in quicker management of the patient. The quicker management of the patient is relative. Okay. And when I say talking about time, I'm talking about that we have control over is the time when the sample you get it and you start processing it in the machine. That's what you have control over. But time, because there's a chain of custody of the sample when it comes to you from the clinic or even from outsourced labs or institutions. Maybe you get a sample from Nyeri, it's brought to Nairobi here to be done for test. You have no control over the time you don't have no control over shipment time. And also, when they ship the sample, they outsource those services. But what the time you have control over is the time to do the test once it's come to the lab.
Thank you, Clifford. I think with that, I can pick one last question. This should be from, let me see. Alexander Mwendo is asking, how many samples can the machine run per day? And then as you answer that, Christine Athoe is asking, she's keen to collaborate on interlab quality checks on those doing STI multiplex panel testing. So if there's anyone, Crispin is keen on to collaborate on interlab quality checks. Thank you, Crispin. So Clifford, about the samples the machine can run per day.
The machine is modular. First of all, depending on your throughput, the machine is divided. It has to go two components: the analytical module and the operational module. So one operational module, depending on your throughput, if you have like let's say less than 10 samples, there's no need of you investing in more modules. So you can use one module. But if your throughput increases maybe to 20 to 30 samples per day, you can increase another module. So you have two modules operated by one operational module, and you can run two samples at the same time. Or if your sample also increases, again, you scale up. So to answer that question in a simple term, depending on the numbers of samples you get per day, we are able to handle from one sample per day up to one sample per day, because the system is scalable. So we cannot put a cap of how many samples you can do per day. Even if you have 100, we'll be able to support you. Even if you have 200 per day, we'll be able to support you. So it does not. I think it's up to Kairos, which is the biggest instrument, running 8 analytical modules, can handle up to 500 samples per day. That's very high throughput.
Thank you, Clifford, and everyone who found time to join into this webinar. I'm sure that this far we have been able to enjoy the presentation. And at this point, I'll take this back to Clifford for his closing remarks.
Thank you very much, Fred. It was very exciting to be in this session today. What I'd like to say is that syndromic testing is here with us. It's a new technology, and it's helping to save a lot of lives, give timely results, support diagnostic stewardship, and support antimicrobial stewardship and reduces the risk of AMR. So we are very, very interested in working with any lab that is interested in acquiring the instrument, and we will support you to support the patient and make Kenya healthier. Thank you.
Thank you so much, Clifford, for your time and also for the perfect presentation today. And it was very informative. And on behalf of Lab Medicine Society of Kenya, I want to take this opportunity to thank everyone who found time to join in. And as I said, as we began this session is KMLTB accredited. And for those who are eligible, it shall attract 3 CPD points that should be uploaded in the next 24 hours. And also you will receive your certificate in the next 24 hours. And also this session is available on YouTube. You can log into our YouTube, that is Lab Medicine Society of Kenya, and always follow the presentation. Otherwise, thank you so much and have a wonderful week. Thank you, everyone.
Thank you.